Thank you, everyone, for joining. So the goal today is to do a focused review on how we manage traumatic brain injury. This is a presentation that was initially developed by Harborview Injury Prevention and Research Center. I made some slight modifications just to clear up the clarity, to make it clear and sync with our protocols. But I just thought this was a good review and wanted to build on it. So we'll begin with a quick review of the epidemiology of traumatic brain injury in Washington State. So of all injured patients who get hospitalized, about 10% have TBI. Of all fatalities, TBI is the cause of death in 29% of injury-related fatalities. So there's something that's very common and has a high morbidity in our injured patients. There are two peaks in terms of who gets brain injured, and I'm sure this fits with your clinical experience. So obviously the elderly have a higher risk, and then young have a higher risk, and then men are much more likely to be injured, to be head injured than women. We are expecting an increase as the population ages, particularly as the baby boom ages and gets into this age category. Head injuries amongst this group are going to become more prevalent. And if patients get hospitalized for falls, there's about a 20% chance that they won't return home. So the key thing in our intervention and our management of traumatic brain injury, there's nothing that we can do about the primary form of injury. That's what results from the direct trauma, and that happens the second of the impact. But then there is secondary traumatic brain injury, meaning there are pathophysiologic processes, swelling, ischemia, that continue and extend the injury. And so the primary focus of our management is to figure out when these things are going on and then to do everything in our power to limit or stop them. And how do we do that? The key thing that we do is we maintain normal physiology to the best of our ability. So we're ensuring that the patient has a patent airway. With respect to the breathing, we're trying to maintain normoxia and normocapnia. So in general, an oxygen saturation 95 to 98%. The reason that we say that is that if you push into higher oxygen saturations, you run the risk of extending that secondary injury, because excessive oxygen generates free radicals that do additional damage to tissue. With respect to normocapnia, although there was a time we would routinely hyperventilate all patients with a suspected head injury, we know that maintaining in that normal range is the best thing for most patients. And then we'll talk about those small number of situations where you want to take patients just a little bit lower than that with respect to their end-tidal CO2. And then with respect to circulation, our goal is to avoid hypotension so that the brain can continue to be perfused. So what are the kinds of secondary injury? There's intracranial hypertension. So you've got this the fixed space within the skull, and then you add blood to that, and then you get increased intracranial pressure, which can ultimately lead to herniation of the brain. Hypoxia, because, say for someone who is traumatically injured and then has a lung injury, that puts them at risk for hypoxia. If someone's head injury is profound enough that it leads to airway obstruction or apnea, then that can lead to hypoxia. So those are things we can intervene on and correct. With respect to hypotension, that can result from spinal shock or from hemorrhagic shock. And so if you're not getting that adequate blood flow, then that will extend the secondary injury. And then hypercarbia um, from a patient that's not adequately ventilating also creates an environment where that secondary injury can be extended. Um, and so these are patients that require a few basic things from us, and then rapid transport to a healthcare facility that can help them. In terms of the symptoms and the signs that we look for, obviously headache, blurred vision, tinnitus. Occasionally, patients will report a funny taste in their mouth, typically from an injury to the olfactory nerve. Obviously, they can complain of weakness, loss of coordination, dizziness, and I would say picking up on those things. Obviously, if someone's gravely injured, that's very apparent. But a concussion is still a minor traumatic brain injury, and picking up on those symptoms can help distinguish between someone who just got a bump on their head or someone who has early signs of a concussion. With respect to signs, these become particularly important as patients get sicker. So decreased loss of consciousness, seizures, pupillary dilation is a sign of herniation. Um, Slurred speech is tricky because obviously we can see slurred speech in patients that are intoxicated with alcohol, and but there's nothing about being intoxicated with alcohol that protects you from having a head injury. Uh, Repeated vomiting, and then increasing confusion, restlessness. So we really depend on your eyes in the field to gather this initial impression. And it makes a big difference if, if the patient was, you had to drag the patient out of the car because they were unconscious, or if the patient self-extricated. Um, the events leading up to the injury, I mean, is this someone who had a bleed or had a syncopal event, and then had a head injury, or are all these findings resulting directly from the head injury? Obviously, the mechanism of injury, and then what people describe after the injury, knowing that particularly with injuries to the side of the head where you hit the middle meningeal artery, those are the common cases where patients will have a loss of consciousness, be profoundly comatose, and then they come back to this window where they're feeling more normal before they deteriorate. So that piece of history is key. Um, so, this is just to review the basics, the things that we want to document. Serial vital signs are particularly important because if patients are developing abnormal vital signs from head injury, that's typically something we're only going to pick up by following the trend of the vital signs. So in overview, your assessment focuses on the airway and then the breathing, um, with note to oxygenation and ventilation, circulation, the GCS, um, with attention to the pupils, and then the indicators of cerebral herniation. So with respect to the airway, you're just ensuring patency and following over time. Is this someone who is slowly losing the ability to protect the airway? With respect to breathing, um, so a continuous monitoring of the SpO2 is important. If you intubate the patient in these high stress situations, it becomes very easy to hyperventilate. And so monitoring the end tidal CO2 becomes really key to ensure you're hitting your targets there. So hypoxemia, because of the other injuries, is common in head injury patients. So again, you just want to continue to target that saturation of 94 to 98%. With respect to hypotension, our goal is a systolic of greater than 100 or a MAP of greater than 65. That's the slow development of hypertension, especially when it's associated with bradycardia, suggests that the patient has increasing intracranial pressure. This is, again, something that we follow and document closely. With shock, which is would be a systolic less than 100 even after you've given 2 liters of IV fluid. You look so not only at the blood pressure, but look at the overall picture of the patient. Are they becoming pale? Are they becoming tachycardic or tachypnic? Are they beginning to shunt from the extremities? But then remember that these injured patients can also have spinal shock, in which case they can have bradycardia. And so that can be a really difficult case to sort out when you have hypotension and bradycardia. And so the key thing there is your exam of the extremities and seeing if there's other signs of a spinal injury. So with respect to GCS, it's the most commonly and reliably understood mechanism to document the level of consciousness. I would say of all the components of the GCS, the motor is probably the most predictive. And you notice in other areas, for example, the LAM score, we really focus on the motor. I think all are relevant with head injured patients, but the motor is probably the easiest to follow and the most relevant. Um, so focus on obtaining the best results. Focus on doing something that really asks the patient to show a higher level of thinking. Obviously, the next step in the GCS, if there's not a response to voice, is to use painful stimulus. I would encourage you to. So one thing I'll do is take my scissors and squeeze the patient's nail, or I will put my thumb into the trapezius. I can't remember the last time I did a sternal rub. When it takes more injury, it takes more effort from you. It's a lot harder to titrate than something like pinching the nail bed or pinching the trapezius, where if you pinch the trapezius, you can just titrate and figure out the exact amount of response that you need to get a painful response. So as a reminder, the components of the GCS: eyes, best motor response, best verbal response. So with respect to the motor response, again, you're documenting the best motor response. It was designed to look at the upper extremity response. Um, and so that's where you're most likely to get you're most likely to get a response, and that's where you're most likely to get your best response. So as when obviously obeying commands is obeying commands. Localizing is moving towards the painful stimuli, whereas withdrawing from pain is just pulling the affected extremity away from the painful stimulus. And then image A here is abnormal flexion, decorticate pulling towards the core, and then decerebrate extremities turning away from the core. So the eyes are particularly important because they can be the key sign of herniation in a head injured patient. And that's because of the increasing pressure on the optic nerve along the floor of the skull. And so in the setting of a head injured patient, a fixed and a dilated pupil has to be interpreted as a sign of impending herniation. So what we most worry about is this unilateral dilated pupil, because that's a sign of pressure directly on that nerve. Um, but do note there are other findings that don't directly indicate herniation, but can give you a sense that something is going on. So, for example, small pinpoint pupils can be a sign of a pontine bleed or an injury. Irregular pupils can be seen with an injury that's directly to the eye. Bilateral dilated pupils, you think about substance abuse. Um, And then gaze deviation, you can see either with seizure activity or with another focal lesion that's impacting the centers that control eye movement. Why do pupils dilate? When you get the unilateral blown pupil in head injury because of that pressure on the cranial nerve. Um, but remember, especially in the setting that you have a patient that's not injured, there are many other causes of abnormal pupils. And then just as a note, if you get atropine in the eye, or if you get neosynephrine or afrin in the eye, that'll dilate the pupil as well. So why do we care about this? We're trying to pick out amongst these head injured patients who is at risk for impending cerebral herniation. Um, so the unresponsive patient, obviously you have to think about herniation. If the neurologic exam is deteriorating, if you have bradycardia and hypertension, especially with irregular respirations, the safe assumption is that the patient is at risk for herniation. And um, and then, as we were talking about before, there's nothing about these other conditions that protect from traumatic brain injury. So patients under the influence of alcohol or other drugs, if any trauma, we still have to consider a traumatic brain injury as a potential cause. And many times the history of trauma is difficult to obtain. In the elderly, particularly those who are anticoagulated, even very minor head trauma can result in head injury. And then think about the other predisposing conditions. So how do we treat? We focus on the airway, on the ventilation, appropriate fluid resuscitation, with some things that we would consider for patients with cerebral herniation. So with respect to the airway, consider spinal motion restriction and maintain the airway patency, and we'll intubate for the patients that are failing to protect their airway, who have respiratory failure from another issue, or if they are rapidly deteriorating, those are patients that can benefit from an early intubation. So we hyperventilate only if there are those signs of herniation. So if no signs of herniation, then we're going for complete normocapnia. The goal would be an end tidal CO2 of 40 millimeters of mercury. If you have the signs of herniation, so profoundly altered, dilated pupil, posturing, then we take that goal down slightly and titrate to an end tidal CO2 of 35 millimeters of mercury. Why do we hyperventilate in those patients? The thought process is that it decreases the partial pressure of CO2, which causes some cerebral vasoconstriction, causes some decreased cerebral blood flow, and some small decrease in the intracranial pressure. So because of this decrease in cerebral blood flow, we really want to save this for the patients that we suspect are herniating. With respect to fluid resuscitation, we discussed we're going to avoid hypotension using normal saline. If the only exception to that was if you suspect spinal shock, then you could consider pressors. With respect to fluid resuscitation, the forearm is an ideal IV site for these patients because they're at risk for seizures. An AC or a hand is more likely to become compromised if they have a seizures. IO is definitely an alternative, but the initiating the IV line does not need to delay transport. With agitation and combativeness, that can increase intracranial pressure. For the patients that have on the lower end of agitation and combativeness, we do have droperidol in the protocol for that. But then patients that are severely agitated and head injured may require intubation. But it's important that we adequately sedate the patients using post intubation ketamine. That's going to decrease their intracranial pressure by managing their sedation well. And then the ketamine also protects against seizures. Consider other causes of the decreased level of consciousness, including low glucose. So, and again, the signs of cerebral herniation, dilated pupils, asymmetric pupils, a worsening motor exam, and progressive deterioration. I think less than focusing on precise values of the GCS, take the whole clinical picture into account. If this patient is rapidly decreasing, you have to assume that they're herniating. Know that obviously fear and anxiety and pain increase ICP. We can treat fear and anxiety non-pharmacologically. We have medicines to treat pain. We have medicines to treat nausea. We can decrease the stimuli, and just airway suctioning is necessary when it's necessary, but we want to keep it brief because that can increase intracranial pressure. With respect to transportation, this, a severely head injured patient is a patient where you're in a remote setting where air medical will dramatically decrease your time of transport. You can consider that. That's fairly rare within our response area, but there definitely are areas where that's a consideration. So patients with mild mild injury can go to any facility. Although remember, the anticoagulated patients should go to a trauma center. Anyone with more profound injury needs to go to a trauma center. So these are the references used to prepare the talk. And with that, and so thank you to these people for the help in preparing this. I will take any questions, and then I will also post in the chat this link for feedback. I want to make sure you're getting the best lectures possible, and I really value any feedback that you can give.
Any questions for Dr. Mott?
Okay, so I see a question in the chat. So the question was, when statistics talking about TBI, does that include anoxic brain injury from overdose and other causes of that nature? No, these statistics are particularly for patients who had traumatic brain injury. But we are, during the pandemic, we have seen an increase in overdose deaths. But that is increasing, but that's independent from these statistics. Other questions? Okay. Well, I'm grateful for your time and attention. And I just finally, the feedback is 2 questions, and I would welcome anything that we can do to make these presentations better for you. Thank you.
Thank you, Dr. Mock.